Hi everyone. Today we are going to discuss about carcinoma larynx part 2. The various things that we are going to discuss in this are the clinical assessment, that is the history and examination of carcinoma supraglottis, glottis and subglottis, and examination findings. What are going to find in examination findings, what to look for, what to have a focus on when you're doing an examination of this patient, and investigations. What investigations would you order for this patient? Which is one of the best investigations? Which investigation is helpful to confirm the diagnosis? Like this. This is again an important part of our questions. This is going to be asked most of the times. If they are going to ask carcinoma larynx, they expect that you should know about the clinical assessment and investigations. Okay, now these are the following heads under which we are going to discuss this presentation. One is history. What are the chief complaints with which the patient is going to present to you? Which carcinoma presents early, which carcinoma presents late, which carcinoma we are going to expect to have a lymph nodes in the neck. Then indirect laryngoscopy for examining of the neck. For an ENT surgeon, it is indirect laryngoscopy ideal. After indirect laryngoscopy, in the indirect laryngoscopy, what are we looking for? Then third one is examination of the neck, so that we can find out any lymph nodes, any extension into the neck, laryngeal crepitus, etc. What is the role of X-rays nowadays with the advent of the CT scan? What is the role of the X-rays in the clinical assessment of laryngeal cancer? So what is the role of the CT scan? How does the CT scan help us to make a better judgment? MRI scan, where do we place MRI scan? When do we need an MRI scan? Then for biopsy, we can either go with direct laryngoscopy and biopsy. Which cases you want to go for microlaryngoscopic and biopsy? Which cases you want to go for supravital staining and biopsy? So these are the three biopsies. These are the two scans, and this is the examination part. This is X-rays. Okay. Now coming to history of the patient who is having glottic cancer. So glottic cancer is the most common laryngeal cancer out of the supraglottic, glottic and subglottic. These are the three types of carcinomas in carcinoma larynx. The most common is carcinoma larynx. It constitutes more than 60% of all cases of laryngeal cancer, carcinoma larynx. The most common site in which the carcinoma larynx in the glottis is not the anterior commissure, is not the posterior commissure, but it is present at the free edge and the upper surface of the anterior and middle third. This is exactly where this carcinoma has started. So, okay, can you see this white one here? This is the normal vocal cord. Okay, this is the this appears to be the right vocal cord. Okay, and this is the right vocal cord. So this is there is an exophytic lesion. There is an ulceroproliferative lesion on the right vocal cord present at the free edge and upper border of the vocal cord. Okay, it is not involving the anterior commissure. It is not involving the posterior commissure. It is not involving the membranous part of the vocal cord. That is the vibratory region. It is getting affected. So this is the most common way, most common site of glottic cancer. What is the symptom with which the patient is going to present to you, is going to come to you to your OPD? Whenever there is a little bit of any hyperemia or any small vocal cord nodule or vocal cord cyst, the patient is going to immediately develop vocal hoarseness of voice. As you would have seen, any case of acute laryngitis, you had a throat infection, and you are going to almost the first day or the second day itself, you are going to have hoarseness of voice. So the moment there is a small growth on the vocal cord, the two vocal cords will not be able to meet each other. There will be a phonatory gap. So there will be a disturbance of the vibration of the vocal cord, and so the patient is going to present to you at a very early stage with hoarseness of voice. So this is the reason why glottic carcinoma presents early, and it is also having a good prognosis. Okay, another reason is it is having no lymphatics. So that is why it is having good prognosis. So hoarseness of voice is the most common presentation and is the earliest presentation of glottic cancer, because the vibratory capacity gets affected early. If the patient is having hoarseness of voice and it does not come to you, and the growth starts going bigger and bigger and bigger and bigger, then the patient is going to have stridor. Here you can see only little bit of there is a little bit of glottic chink, there's a little bit of space available for the air to pass. Then the patient is going to have stridor. He's having noisy breathing, and he's going to have laryngeal obstruction. That is, the patient is going to have shortness of breath, breathlessness. Yeah, I'm not able to breathe properly. If I walk a little bit, I get a lot of breathlessness. So breathlessness, shortness of breath on exertion. So these are the later presentations. One is stridor and laryngeal obstruction causing breathlessness. These are the late presentation. The first and earliest presentation is hoarseness of voice. Lymph nodes, in the case of carcinoma glottis, we talked about it in the previous presentation. That is never seen. You will never see a case of carcinoma glottis if the growth, as long as the growth is confined to the vocal cords. As long as the growth is confined to the vocal cords, there will be no metastasis. Once it grows into the supraglottis or into subglottis, then you will have lymph nodes. So in a case of carcinoma glottis, he will have hoarseness of voice, and he will present to you early, and there will be no lymph nodes. Okay. As the carcinoma growth starts increasing in size, you may find the stridor and laryngeal obstruction, breathlessness. Another point, glottic carcinoma, 60% of the cases of laryngeal carcinoma, glottic carcinoma, is the most common glottic carcinoma that we have. And the site of origin of this glottic carcinoma is the free edge of the vocal cord and the upper surface of the vocal cord, of the membranous part, anterior and middle third. Okay. Now coming to supraglottis. Supraglottis is the second most common cancer of the laryngeal cancer after glottic carcinoma. It constitutes 35% of all glottic carcinomas. As I said, yeah, it is less frequent compared to glottic carcinoma. It is less frequent. What are the sites there? We said it is the free edge and the upper surface of the anterior and middle third. Here, the most common site of origin of glottic carcinoma is the epiglottis. After the epiglottis, you have the false cord. You may have a growth here. This is the first most common. The second most common. Third one is the araepiglottic folds. This is the third most common site. The first site is the epiglottis. Second site is the false cord. The third site is the araepiglottic fold. Sorry, this one is the araepiglottic fold. This is the piriform fossa. Okay, sorry, this is the epiglottis. This is the araepiglottic fold. This is the araepiglottic fold. This is the arytenoids. Okay, this is the epiglottis. Sorry. So this is the araepiglottic fold, and araepiglottic folds are the third most common site. The first most common site is the epiglottis. Then we have the false cord, and then we have the araepiglottic fold. What are the symptoms? Now look at this growth here. This growth, it is an ulceroproliferative growth. It's a dirty looking growth here, but there is it is neither causing any problem to the vocal cord. The vocal cords are fine, perfectly white in color. The piriform fossa is also not affected because the growth is very far away from the piriform fossa. So there is no hoarseness of voice, no dysphagia. So if the patient is going to, the supraglottic carcinoma is going to have a symptom, the growth has to be large enough. It has to start affecting the vocal cords, the glottic area. Then the patient is going to have hoarseness of voice. So if the patient is having, a patient with supraglottic carcinoma is having hoarseness of voice, it has become so big that it has gone on to the vocal cords and it's causing hoarseness. So it's a late symptom. So what are the most common presentations? It's often silent, as we said, because it has to grow to quite a large size to produce symptoms. The first symptom that they can present to you is throat pain. Okay, throat pain. This was one of the features. I saw a case of carcinoma of the larynx. It was probably submucosal. We couldn't really see it even on video laryngoscopy. The patient was complaining of throat pain and ear pain. I remember this case. And only when we did an upper GI endoscopy, where only then we could really find out that there was a carcinoma. Okay, so a carcinoma of the upper esophagus can also present in the similar way. Okay, the patient is going to have throat pain, dysphagia, pain in the neck, referred pain to the ear. So one of the sayings in carcinoma is if the patient is having pain, which means that the nerves are getting infiltrated, which means that it is already in the late stage. So pain in a case of carcinoma means patient is already in the late stage, maybe third or fourth stage. Dysphagia, it has to become so big that it should start blocking the piriform fossa. Yeah, okay. Then you have dysphagia, referred pain in the neck because of infiltration of the vagus nerve, because that is supplying both the ears and the and the throat. A mass of lymph nodes in the leg. The patient already has a neck metastasis. So these are the 4 ways the patient with supraglottic carcinoma is going to present to you. One is patient having throat pain. Second is dysphagia, and the third one is referred pain to the ear, referred pain in the ear. So these are the 3 most common ways in which a supraglottic carcinoma is present to you. Also neck node. So these are the 4 common ways in which the patient is going to present to you. Hoarseness is a late symptom. Most of the times it is silent. Late features, it is having distant metastasis. The patient has already gone into the larynx, into the liver or into the lungs, and the patient can have weight loss, respiratory obstruction, and halitosis. Halitosis because there is so much of dead tissue here from the mouth that the patient is going to present with foul smell from the nose. Foul smell from nose. Okay, so these are the late features. Weight loss means patient is already having cachexia. So that is, you can expect that the patient is having distant metastasis, respiratory obstruction, and halitosis. So these are the late features. Lymph nodes, we already talked about in the first thing. The draining area, the drainage areas of the supraglottis are the upper and the middle deep cervical lymph nodes. Okay, so just summarizing it. Supraglottis is the second most common cancer after glottis. Most common site is epiglottis. It's often silent. If the patient is going to have symptoms, it's going to be throat pain, dysphagia, referred pain to the ear, and mass of lymph nodes in the neck. If the patient is having hoarseness of voice, it means that it is already late presentation. And these late features of weight loss, respiratory obstruction, and halitosis, these are very late features. Okay. Then the lymph nodes are the upper and middle deep cervical lymph nodes, as well as the lymphatic drainage. Okay. Now coming to subglottic carcinoma, this is a rare carcinoma. It is less than 1 to 2%. Okay, 1 to 2% of the carcinoma larynx subglottic cancer. I have never seen a case of subglottic cancer per se in all these years. What is the symptom? Now, as you can infer, the growth in a subglottic cancer appears more like a nodule, right? It looks like a nodule, while in a case of supraglottis and glottis, it looks more like an exophytic ulceroproliferative kind of a lesion. Okay. Symptoms, because this is the airway, the stridor and laryngeal obstruction are the presenting symptoms, and it has to become quite big. So cause stridor and laryngeal obstruction, the patient is not going to present early. A subglottic carcinoma patient is not going to present early. So he's going to present late. By the time it's already stage 3 or stage 4. Hoarseness of voice can be present only if the vocal cords are involved. This is also a late presentation. So the presenting features are stridor and laryngeal obstruction, and that too it is late, and hoarseness only if the vocal cords are involved. Lymph nodes. So subglottis drains into the lower deep cervical lymph nodes and mediastinal lymph nodes, either directly or through prelaryngeal or pretracheal or paratracheal. All these nodes are present right where there is a carcinoma, right? Pretracheal, prelaryngeal, paratracheal lymph nodes, and from there it will go into the deep cervical lymph nodes, lower deep cervical lymph nodes, and the mediastinal lymph nodes. Okay, this is the end of the history, the symptoms with which the patient is going to present to you. Okay, now dictum is, there are some things, okay. Any male patient who is like 40-50 years old, any male patient, smoker, he is presenting to you with hoarseness of voice. The first thing that comes to your mind is it is cancer. Unless and until proved otherwise, it is carcinoma. They should be male, it should be age group of 40 to 50 years, 40 to 70 years, and the patient is a smoker. Now, this is a very important part. Smoker and is presenting with hoarseness of voice. Think of carcinoma. First, you rule out carcinoma by doing indirect laryngoscopy, video laryngoscopy, or direct laryngoscopy. Only when you have confirmed that it is not carcinoma, you think about the other diagnosis. The first diagnosis is always carcinoma. So that is what the dictum says. Any male with a history of smoking, presenting with hoarseness for more than 3 weeks duration, that is, this is a chronic hoarseness, more than 3 weeks, it has to have laryngeal examination to exclude cancer. Laryngeal examination must be done in such a patient to exclude cancer. Now, we are putting all this in a simple box. If you can write this box in the exam, your history is done. Okay, what are the features? Supraglottis, glottis, and subglottis headings. Supraglottis is asymptomatic for the long time, but it is richest in lymphatic, so it has more chances of getting neck lymph nodes. Okay, so subglottis also is asymptomatic and is asymptomatic. Okay, so glottic carcinoma is the most common carcinoma of the larynx. Most common site is the free edge of the vocal cord. This is also the carcinoma larynx with the earliest presentation, because a little bit of change in the vibratory capacity of the vocal cord, the patient is going to have hoarseness of voice. Okay, so supraglottis is asymptomatic for a long time, richest in lymphatics. Carcinoma glottis, most common carcinoma, free edge of the vocal cord, and it is the carcinoma with the earliest presentation. Subglottis is asymptomatic for long. What does it present? Presentation, is it late? Supraglottis is late presentation in an advanced stage. Subglottis also, if the presentation is late in an advanced stage. Only carcinoma glottis presents early. Okay, both supraglottis and subglottis present late in an advanced stage. What is the chief complaint? Chief complaint, the presenting symptom or the earliest symptom which the patient presents to you. Carcinoma glottis is hoarseness. Supraglottis, it is dysphagia, pain in the throat and referred pain in the ear. Last is hoarseness only when the vocal cords are involved. So dysphagia, pain throat, referred pain to the ear. This is the way supraglottic carcinoma is going to present to you. Subglottic carcinoma is going to directly present to you with stridor in the late stage. Okay. Now neck nodes. Neck nodes in the supraglottis carcinoma, you are going to see it in the upper and the middle deep cervical lymph nodes. In the subglottis, you are going to see in the lower deep cervical and mediastinal lymph nodes. Sometimes in the paratracheal and pretracheal lymph nodes. Okay, prognosis. Prognosis is best in carcinoma glottis, whereas it is poor in supraglottis, and it is worst prognosis in subglottis, because it is very close to the mediastinal structures, and the carcinoma is already advanced stage when the presents to you. So the chance that you are going to save the patient out of subglottic carcinoma is very rare. So this is having the worst prognosis. So try to remember this table if possible. Very easy way of putting everything, and very easy way of telling to the examiner that you know everything about supraglottis, glottis and subglottic carcinoma. Coming to indirect laryngoscopy. This is the first, first line of examination for an ENT surgeon. Indirect laryngoscopy. You use an indirect laryngoscopy mirror. You do an indirect laryngoscopy mirror. With the left hand, you are pulling the tongue outside by using a gauze piece, and you're pushing it against the soft palate and focusing your light on the mirror and trying to see the laryngeal structures. So what do you want to see in a case of carcinoma larynx? One is appearance of the lesion. How does it appear like? What is the vocal cord mobility? Okay, and extent of the disease. Okay, so carcinoma glottis, most common type is exophytic. It appears like a cauliflower. Okay, so if I draw a ideal examination findings, so this is how we draw it. Right side, left side, you mark it. These are the vocal cords, epiglottis, vallecula, base of tongue. These are the false cords. These are the false cord. This is the arytenoid. This is the postcricoid area or the posterior commissure area. This is the piriform fossa. So there may be a growth of the vocal cord. There may be a growth on the false cord. There may be growth on the epiglottis. Okay, so you will see an exophytic lesion. Sometimes the just appears like it has been nibbled by rats. Okay, like there's an ulcerate. There is no there is no growth on top of the mucosa. There is a growth under the mucosa. This is called the infiltrative type. And this appears ulcerative. Okay, it may appear as in the case of subglottic carcinoma. It can appear just as a nodule. The surface is smooth, or sometimes, as the description is, in the anterior commissure area, if there is a growth, it appears like a granulation tissue. Okay, so it may appear exophytic. It may appear ulcerative. It may appear like a raised nodule. It may appear like a granulation tissue. But most of the times we see a ulceroproliferative lesion, and that's how we describe it. Ulceroproliferative lesion of the vocal cord or the epiglottis. So this is the first thing that you look at it and you notice. Second one is, what is the mobility of the vocal cord? That is denoted by this symbol. If the vocal cord mobility is gone, we just strike it. If it is impaired, we put 2 lines. If it is moving normally, we do not make any strike marks. Okay, so you look for whether the movement of the vocal cord is impaired or fixed. Impaired means stage 2, fixed means stage 3. So this is so important when you say whether it is a impairment or fixity of the vocal cord. Why does the vocal cord get fixed? It indicates that the tumor has infiltrated into the thyroarytenoid muscle. Now, this is a little bit of an anatomy. So this is the thyroarytenoid muscle, the muscle that is present in the vocal cord, that is causing the vocal cord to move. If the growth is on the free edge of the vocal cord, it grows into the thyroarytenoid muscle. Obviously, the vocal cord is going to get impaired, the mobility is going to get impaired or fixed. It can go to the cricoarytenoid joint, it can fix that and can cause vocal cord fixity. Or it can grow beyond that and affect the recurrent laryngeal nerve, which is present right behind at that area. Then that also can cause vocal cord impairment, mobility impairment or fixation. Okay, this is one of the questions. When do we expect that the vocal cord is getting impaired or fixed? When there is involvement of the thyroarytenoid muscle, when there is involvement of the cricoarytenoid joint, or when there is involvement of the recurrent laryngeal nerve. Now, once we have got these two things, now the third one is extent of the disease. Now you have to write down in your notes whether there's a growth of the vocal cord extending onto the epiglottis, there's a growth extending onto the false cord, there's growth extending onto the araepiglottic fold and arytenoid, or extending into the piriform fossa. So what are all the parts of the larynx and the extralaryngeal tissues that this growth has already gone into? So that is also we have to describe in indirect laryngoscopy. So if it is extended into the vallecula, that means it is extralaryngeal spread of the disease, base of tongue, more poor prognosis, piriform fossa, more poor prognosis. So if it has extended beyond the larynx, so beyond the larynx also we have to note, and inside the larynx also what are all the structures that it has involved. So this is what we have to note down in indirect laryngoscopy. Now coming to examination of the neck. Once we do an indirect laryngoscopy and whether we say whether there is a carcinoma, whether an exophytic growth or whether there is an ulceroproliferative growth or not. Second is examination of the neck. So systematically we should start examining level 1 first under the submandibular area, submental area, level 2 upper deep cervical, level 3 middle deep cervical, level 4 lower deep cervical, level 5 this is the sorry, I'm not getting the word. Posterior triangle lymph nodes. Sixth one is this is the front part, pre-tracheal, pre-laryngeal and all that. Okay, so systematically we go for whether there is any lymph nodes. Once we have a lymph node, we have to note whether what is the size of the lymph node, whether it is less than 3 centimeter, whether it is more than 3 centimeter, whether it's less than 6 centimeter. So these are all going to come in staging, okay? Whether it's 1 centimeter, what is the number of lymph nodes, how many number of lymph nodes, what is the mobility of the lymph nodes, and how hard is it? It is soft or hard. Okay, we have to note that. And whether if the growth is on the left side of the hemilarynx, and now you have to note whether the lymph nodes are on the left side, whether lymph nodes on the right side, or lymph nodes on both right and left side. That is whether it is unilateral, bilateral, or contralateral. So this is the first thing that we check for the lymph node, nodal metastasis. Extralaryngeal spread of the disease. Suppose there is a node and also it is moving up with deglutition and it is hard, where you can say that it is extralaryngeal spread of the disease into the strap muscles. We also look for laryngeal tenderness. If you press on the larynx, whether there is any laryngeal tenderness. You also check for whether any laryngeal crepitus, whether when you move the larynx side by side, is it moving on the prevertebral tissues, on the vertebral tissues, you get a laryngeal crepitus. Okay, loss of laryngeal crepitus indicates post-cricoid carcinoma. Okay, and whether there is any laryngeal widening, this is also something that will give you an idea that it is a late stage of the disease. Okay, you also palpate this front part of the neck to notice what is the status of the thyroid gland or whether there is any strap muscle involvement. So what do we look for in the examination of the neck? First thing is whether there is any nodal metastasis. Second one is whether there is any extra laryngeal spread of the disease. How do we do that? By laryngeal tenderness. Laryngeal tenderness in a case of carcinoma larynx indicates that the stage is already in stage 4 and you may have to go for total laryngectomy. Okay, complete total laryngectomy. Okay, so this is the examination of the neck. Coming to radiography. Till the examination of the neck, this is clinical assessment, history and examination, clinical assessment. Now, coming to radiography, in the age of CT scan, we rarely go for X-ray of the neck, but we do as part of any case which we want to take up for surgery, where we are preparing the surgery, pre-anesthetic assessment, chest X-ray is compulsory. Okay, in the chest X-ray, what do you look for? Whether there's any coexistent lung disease. Most of the patients of carcinoma larynx are smokers, so there will be some lung abnormality, there will be some COPD kind of features. Okay, so you look for that. Whether there is any pulmonary metastasis, means it is extra, distant metastasis are also present. Whether there is any mediastinal loads, this is more significant in subglottis, but is also subglottic carcinoma, but can also be present in glottic carcinoma, which is extended beyond its confines. Okay, so you look for coexisting lung disease, pulmonary metastasis, and mediastinal lymph nodes in the case of chest X-ray. Soft tissue lateral view of the neck, this is only for literature purpose. We never do this because CT scan is there. Before the CT scan, you can know about the extent of the disease, involvement of the pre-epiglottic space, or destruction of the thyroid cartilage. So these things you can see with a soft tissue neck, extent of the lesion, involvement of pre-epiglottic space, and destruction of thyroid cartilage. Okay. Now coming to CT scan. CT scan is the first line of investigation in a case of carcinoma larynx. Okay, multi-detector CT. Multi-detector CT, MDCT is the first line investigation in a case of carcinoma larynx. What is multi-detector CT? Is nothing but multiple thinner slices. So if you want to check the larynx of this patient, you can get the slices very close to each other. So when you take a very close slices, you can get a more complete picture of the disease. What is the extent of the disease, whether it has invaded into the pre-epiglottic space, whether it is involved into the paraglottic space, whether it is got involved, whether the pre-vertebral space is involved, So like this, you can find out the extent of the tumor. Clearly we can see, this is a case, this is a CT scan. Here you can see that this is the carcinoma. This has already gone. The left-sided thyroid cartilage has been totally invaded. Okay, so you can, without a CT scan, you cannot do staging. Just for the staging purpose, CT scan is compulsory. So that will tell you the extent of the lesion, extent of the tumor, whether there is pre-epiglottic and paraglottic space involvement, whether there is any destruction of the cartilage, and also whether there is any lymph node involvement. So you can see the lymph nodes are also involved. I think these are the lymph nodes. Okay, so lymph node involvement is there or not also, we can find out in a case of CT scan. Okay, so CT scan is the first line investigation. So this is also a NEET PG question. The first line of investigation of a case of carcinoma larynx is a CT scan. MRI scan is a very useful adjunct. It helps the CT scan, but without a CT scan, there is not much use for an MRI. MRI gives soft tissue picture very well. So a more accurate assessment of the cartilage involvement, pre-epiglottic and paraglottic extension of the tumor, you will get it with MRI. Now coming to biopsy, why do we perform a biopsy? Always when you put the diagnosis of the patient before getting the investigations, you always write it like growth vocal cord. You never put the diagnosis saying that carcinoma vocal cord. You never put this because this is a diagnosis. It's a provisional diagnosis. Okay, without getting the biopsy, without finding the histological type of the tumor, you never put a diagnosis of carcinoma vocal cord. You never tell to the patient that the patient, you are having carcinoma by looking at the growth in the vocal cord. You say that you are having a growth in the vocal cord. It may be carcinoma, it may not be carcinoma. We cannot say whether it's a carcinoma definitively without getting a diagnosis, without getting a biopsy. So what is the purpose of the biopsy? For diagnosis and to confirm the histological type of the tumor. Histological type of the tumor, as we already said, whether it is squamous cell carcinoma or other types. Squamous cell carcinoma is the most common type of carcinoma glottis, and also whether it is well differentiated, whether it is anaplastic, what is the the morbidity, the attack ratio of this growth, whether it is a more virulent, sorry, I'm not in the right word, it is not more aggressive kind of tumor. We can find out by the histological type. The pathologist is going to tell you. Then the first type of biopsy and the most common type of biopsy that we perform is a direct laryngoscopy and biopsy. This is the diagram of the laryngoscopy and biopsy. We just spray the nose, spray the mouth, oral cavity and the pharynx, ask the patient to keep the anesthetic solution 10% xylocaine in the mouth for quite some time, and this is the direct laryngoscope. Holding it up, we look at, this is the eye of the examiner, he looks through it into the larynx, okay, and you take a cup forceps and take a biopsy from the growth of the thing. Okay, what is the function or the use of direct laryngoscopy? In the ideal, you do not see some areas of the larynx. We'll come to that. So we can see the hidden areas of the larynx. We can make a more appropriate assessment of the extent of the disease, and we take a biopsy from the growth. So this is the function of direct laryngoscopy and biopsy, to look at the hidden areas of the larynx, to find out the extent of the disease, and more importantly, to take out the biopsy. So this is the most common way, or the first line, or the most common way in which you try to take a biopsy of the patient. Because this does not require anesthesia, you can do it with a local anesthesia with a little bit of sedation, and you can take out the biopsy. Okay, biopsy. Without biopsy, we cannot go any further. Next thing is you can go for microlaryngoscopy and biopsy. This is like you have to take the patient to the operation. This can be done in minor OT also sometimes. Minor OT also it can be done, but this one requires general anesthesia. You have fixed this direct laryngoscope to the you have fixed it, and you are using a microscope, and you are looking through the direct laryngoscope into the larynx, and you are taking a biopsy from the lesion. So this is like, because it is general anesthesia, this is like a little bit more riskier procedure compared to the local anesthesia. But basically, microlaryngoscopy for small lesions, a small vocal cord growth, is there. You don't know, you're not sure whether it is a leukoplakia or is it a growth of the vocal cord. Okay, it can be a leukoplakia also. So when you are having such a kind of a doubt, I mean, the lesion is so small that when the patient will be moving in a direct laryngoscopy and biopsy, you may, if the growth is quite big, you can take it, but if the growth is quite small, you will have to take up the patient for microlaryngoscopy. You can have a more accurate assessment, and you can take a more accurate biopsy with microlaryngoscopy. Supravital staining. What is supravital staining and biopsy? So the taulidyne blue is used. You put taulidyne blue on the lesion, you wash it with saline, and then you examine it under a microscope. So this is also microlaryngoscopic surgery only. But now you want to differentiate whether it is a leukoplakic patch or a carcinoma in situ. So first is leukoplakia. This is a pre-malignant lesion. If the leukoplakia progresses, it will become carcinoma in situ. If it progresses, it becomes a carcinoma, right? If it is to differentiate between leukoplakia and carcinoma in situ, you put taulidyne blue on the lesion and you wash it with normal saline. Leukoplakic patch does not take up taulidyne blue. Carcinoma in situ takes up taulidyne blue. Suppose this is the leukoplakic patch. It appears white in color, thick white patch. But only this part has taken up the taulidyne blue dye. So this is where you have to take the biopsy. If you take a biopsy from here, it's going to come leukoplakia. If you take it from here, it's going to come as carcinoma in situ. So you can select the area for biopsy in a leukoplakic patch. So the three types of biopsy: direct laryngoscopy and biopsy, most commonly done. Next one is microlaryngoscopy and biopsy, where when there are very small lesions, when you want to differentiate it between a leukoplakia and carcinoma in situ, when you want to take a more accurate biopsy, you can go for microlaryngoscopy. Supravital staining with taulidyne blue is also used when you want to differentiate a lesion, carcinoma in situ, from leukoplakia. Okay. Now coming to this one point that we want to talk about, the hidden areas of the larynx. Now this is also one of the important questions. What are the areas that are hidden from the larynx? So this is an indirect laryngoscopic picture that we see here. What are the things? We see the base of the tongue, we see the vallecula, we see the epiglottis, okay, we see the ariepiglottic folds, arytenoids, posterior commissure area, postcricoid area, okay, and we see the true cords, we see the false cords, okay, but we do not see the infrahyoid epiglottis. This we see the epiglottis, this is the suprahyoid epiglottis. This part, sometimes there may be a growth hidden there. I have seen such cases where the growth is only, you cannot see it on indirect laryngoscopy, but you can see on video laryngoscopy. Okay, infrahyoid epiglottis. So, sorry, this is the epiglottis. It's a leaf-shaped structure. This is the infrahyoid epiglottis. This part is hidden. And because this epiglottis is coming forwards, the anterior commissure is also hidden. Subglottis. This part is not so clearly seen. You can directly see the trachea, but as we have seen, right, this is the vocal cord and this is subglottis, and from there the trachea starts. So if there is a growth here, you cannot see. Subglottis is also a hidden area, and ventricle between the true cords and the false cords also you cannot see on indirect laryngoscopy ideal examination. So what are the hidden areas of the larynx? One is infrahyoid epiglottis. infrahyoid epiglottis, you cannot see. So these are the hidden areas. Next one is anterior commissure, which is after infrahyoid epiglottis comes anterior commissure. Then you cannot see the subglottis. Then you cannot see the ventricle. So these are the 4 areas that you cannot see on indirect laryngoscopy, which you can see on direct laryngoscopy. Okay. Right. With this, we come to the end of part 2, where we have learned about the clinical assessment, the history, clinical examination, and investigations. This is a very important part. You may be asked this in your exam. Thank you for the patient listening.